Hi, I'm Becky Malvey, Professor at London South Bank University, and I want to share with you some thoughts, not only on the things that we found that worked and didn't work during the crisis of the pandemic, the initial crisis, but also where we should be focusing our efforts now, what's getting lost in the current struggle to just keep things going. And I just wanted to remind us that what's the point of health services? What's the point of what we're trying to do here? And sometimes in our sickness world, we seem to think the point is cure. But actually, I really like this sense that what we're trying to do is help make life worthwhile. That as we're beginning to support people in their health decisions and in their and in how they manage their health, what we're trying to do is make decisions that enable people to live worthwhile lives, not just to survive. So when we undertook the survey, Innovation in the Pandemic, as a result of some of the clinicians that we work with ringing us up saying, oh my goodness, there are some things that are really amazing that are working that have never worked before, and some things that are horrific and that we mustn't ever go back to. We very quickly in March and April put together a survey and had a significant, huge response to that survey. I'm going to share those results with you now. You've seen some of that on my blog already, but let me share just the headlines of those before we get into, so what should we be doing now? So the first thing was that the big picture was sorted, that that staff felt properly valued. Now, this meant that the clinicians felt like the NHS was in service to their work, sometimes for the first time for many years. Not to the extent that not only did what they say matter, what they said counted, but they were properly supported to do their work. And that included food and drink 24/7. One doctor said, I haven't had hot food and drink at night for 10 years. That's amazing and horrific. They also talked about the support for their well-being and the struggle of COVID, particularly the struggle of the pressure, the decisions, the struggle of helping people cope, the deaths, all of that. But those are struggles that clinicians deal with also on a daily basis where they haven't been supported over the years. Why aren't we supporting people who watch and hold the hands of people that die? Why aren't we supporting people who are having to cope with very significant, rapid decision making that will ultimately affect people's lives? We should be doing that. And so that was happening during the pandemic. Not only was it happening that people could get food and drink and were properly supported, they felt valued, not only by the NHS, but by the wider society. A nurse said, I'm not just a nurse anymore, I'm a nurse. That really matters, that people feel proud of their work. I see that pulling back at the moment. I see clinicians tired, stressed, anxious, as if suddenly their job is just to hit targets, to get things back to where they were, to be at 100%, to get the waiting list down. And all that work we were doing on supporting them could be lost. But it's up to individual organisations, general practices, community trusts, hospital trusts, to nurture that. It's not expensive and it really matters. So in this environment, clinicians weren't doing business plans to support the thing they desperately needed to look after their patients. They were being given it. They were being asked by those well-connected, visible, engaged leaders, what do you need? What do you want? Now, I'm not going to talk particularly about 21st century tools. We all know the impact of being able to triage quickly, being able to get into people's homes, the amazing value actually for a GP of being able to dial into someone at home, see their context, meet their partner, meet their family, and have a conversation that really does reflect their current lives. I know that doesn't work for everybody, but it certainly works for some. And it's certainly an improvement on people struggling into general practice. I know we're moving to that for outpatients. Maybe that's going to allow us to have much better collaborative decisions between primary care, secondary care, and the person and their families. That has to be good. So I'm not going to talk about 21st century tools because I know that's going to be a huge focus of the NHS's work. And so it's something you'll be very familiar with. The visible and connected engaged leaders, I'm going to give you an example in a minute of a senior leader and their experience of that. And also these care efficiencies, that things have just been sorted. Suddenly things were unblocked that had been blocked for ages. Things got done that could be done. People that needed printers got printers. It just happened. Suddenly, all those things that were difficult and impossible to do were sorted and done. What else worked? Oh, here's the story from the chief executive. This is the chief executive of a hospital in London. And I love this quote because it's a narrative about the guilt he felt around being able to do really great work at a time of immense suffering, because he felt like he was able to do the job he really wanted to do and thought this chief exec's job was all about properly supporting clinicians and citizens to achieve the health they need to achieve. So he had a real sense of confidence at the end of this. But really, I think many chief execs say the same thing. They've done their best work. They've done what they thought they were here for. They've been able to really support the NHS to be its best. They're not fighting upwards and fighting outwards, or they weren't. They are again now. Let's have a look at the picture. So having sorted that, we saw these things happen. The health service and local health systems joined up to get things done. Discharge to assess is the best example I've seen of this. The power battles, the difficulties of a joint assessment that have been rattling around the system for years, really holding up people being able to be assessed in their home so that they can live at home as well as they possibly can. Suddenly that fell away. Joint assessments overnight became possible and were put in place. Staff worked brilliantly as real teams. Now, what we saw here was that a doctor saying things like, I'm not a safari doctor anymore. I don't roam the hospital with a bleep not belonging to anybody or anywhere. I'm part of a team. It's so great to be part of a team. People know me, I know them. This is really, really important to all of us, that we need some sense of not just feedback loops, being able to get some feedback about the work we're doing, but a sense of belonging, the sense of contributing, the sense of making a difference. You can see that when you're in a team. And actually what we saw was a rise in good team healthy behavior, checking in, how are we, particularly because people had complex lives at home. They had things they were coping with, whether it was kids out of school, or whether it was families who themselves had COVID, or the clinicians themselves experiencing COVID. So everybody came to work when they came to work with a level of anxiety that the rest of the population was feeling, and also a sense of real need, real purpose. But you need to check in the stress of it, the exhaustion of it, the decision making, the rapid learning. So checking in, creating some headspace for learning and checking out. Learning teams were what we saw in the height of the pandemic, in the first phase of this crisis. And then we saw staff stepping up. Suddenly boundaries between clinicians, between specialities fell away. People collaborated in service to solving these difficult problems, learning together, trying to design the best care possible. Clinicians used data. They phoned and got in touch with other clinicians around the world struggling with the same issues. They brought the best of professionalism, which is how do we find out the best thing we can do for this person in this place at this time. Again, scrutiny, collaborative learning, really important parts of professionalism, something that we have perhaps not seen to the extent we should have seen across the health system as clinicians vie for territory and power, as specialisms delineate from each other in order to ensure that they have a career path and a future. We've lost a bit of that. Some of the self-serving nature of professionalism, of expertise rising to the top, has got in the way of collaboration. And now we have a system that can make decisions based on needs and think proactively. Mutual decisions with citizens as partners. We've seen, particularly in primary care, some fantastic examples of clinicians who are very quickly responding and working with citizens via WhatsApp, via telephone, via Accurex, by video consult, by e-consult, a more collaborative space where citizens are beginning to contribute to their diagnosis, bringing their intelligence in, quick support for them with follow-up and check-ins, whether that might be by phone or WhatsApp. Really amazing to see people working together. That shifts the relationship. This is not a dependence model now, it's an interdependence model. And then working closely with communities. And what we saw was the NHS having to ask for help, saying, we can't do this, we need your help. and the space that communities stepped into, not only to do shopping, but to ring up people who were lonely and isolated, to contact people who were on the sheltered list, to step in and help out, to connect people at street level to their neighbours and to make new friends. The collaborative sewing groups, the knitting groups, the book clubs, the things that have emerged out of that space, whilst people weren't at work, whilst people were really thinking about how they can help out in the NHS's endeavour. The NHS had to say, we can't manage and we're vulnerable, and the community steps in. We mustn't lose that. The idea that the NHS will orchestrate and design how a community steps into and supports each other is wrong. Most of healthcare happens outside. It happens in people's homes. It happens between families, relatives, carers, and their friends. We have to create the space and step out of the way for that to happen. We can't manage it. We have enough to do in the NHS. We have to recognise the legitimate role the NHS can play to inform and support that to happen. But it also means we have to step into a space as legitimate community leaders and say and work with our town councils, our parish councils, our voluntary groups locally, and say, this is what we need and this is what we can do. But also to say thank you, to provide some efficacy. Back to the same issue of staff being valued, we have to value our community carers too. And of course, some things went really, really badly, but it really framed some of the things that were evident in the NHS that suddenly didn't seem necessary, some of the CQC stuff. Why isn't CQC just the sort of baseline? Why is it the whole system's organised around regulation, rather than regulation being the sort of safety net for a higher performing system? Because what we saw as we set up this system over that time, over April and May, was this model of care that we mustn't lose, that actually replicates what you see in high-performing health systems. These are the characteristics of high-performing health systems that we see from NUCA, from Intermountain, from Jönköping, that leadership and strategy is absolutely aligned around quality, common goals, networks of care, that clinical leadership is properly supported by professional management, not the other way around. Their shared decisions with patients and families. That the design of the services is around robust primary care teams at the centre of delivery, not the periphery, not the underfunding, not the last resorts, the absolute linchpin of the NHS. Better integration, seamless transitions, not multiple handovers that get in the way. Professional cultures around learning and improvement. I think this is about learning strategies that we see in the improvement capabilities, an enabling environment. And then this improvement capabilities, i.e. our quality work, a proactive approach to skills, good information and data to support decision-making, good learning strategies, and engaging citizens in their care and the design of their care. That's what high-performing health systems around the world look like. And temporarily, we had some of the features of that. And those are the things that we must focus on and not lose as we move into the next stage. But let's have a look and say, given that that's where we are, given that that's the culture that we need to be engendering, where do we start? What sort of issues do we need to be tackling? Now, I'm very struck around the issues around people and workforce, because what I found was that when you look at how the NHS responded to those people and workforce issues, they tend to call it that, workforce, rather than people. And so the sort of implementation side of what do we do next is about, we've got to support people working from home and we've got to coordinate resources. But actually what we found were these features on the right-hand side of your screen, that actually the people and workforce work that we have to do is have teams that learn. Those are the generators. That's the most important thing we should be paying attention to. These sort of healthy conditions of teams working, people being part of a team, having the support to be able to do the team work, getting coaching as teams, not having safari docs, people being valued, their work is meaningful, and time to check in and check out. So the first thing I would say to any leader is we've got to focus on making sure that our teams are as effective as they can be and are supported to do the great work they should be doing. And I would include in that data to enable them to make good decisions and review. Most of our data is performance management data. There's shed loads of data analysts sat in offices pumping stuff up to NHS England. Data is not at the front line where people need it to help them properly review their practice. And in all high-performing health systems, that's where it is. So realign your data team, your data scientists, and ask clinicians working with citizens and patients, what data do you need to make effective decisions and to scrutinize and peer review your work? The second thing is we have to design services around needs. At the moment, we design services around demand. There are some areas that we have clearly missed and that have been prevalently obvious in the pandemic. They have become visible. Children, people in poverty, people from Black and ethnic minority communities, and people with very complex needs. We really, really have failed those folks. We have not organised and designed services around meeting those needs as well as we should have done by any means. Here's an example of children and young people's access to general practice from the work we've been doing with general practice. And what we found is that between the ages of 7 and 24, young people and children are not accessing GPs. What we have found, actually, I've only asked one health system this, but I asked the leads out of our system, and they were saying 40% of their calls was from this age group out of ours. So they're going somewhere, they're just not going to general practice. That means we've got it complete, the model of delivery for children and young people completely wrong. Now, if primary care funding is to deliver primary care services, then we should be looking at the needs of the entire population and designing services around them. If primary care is there to offer appointments, then clearly it's working. So if you offer appointments, this is what you get. You get the people that know how to get appointments, getting appointments. And as you can see, that's the older population. The colours are different disease categories. Don't worry about them. I'm more interested in the age, the people that meet those who get the services. So we need to reach in. And what we found in the pandemic was schools really worried about kids in terms of safeguarding. Schools really worried about kids in terms of their education. And general practice also worried about some of these children. And where they've collaborated, it has been fabulous. And actually, one of the things you can do is use the additional roles money for social prescribing. I've got a blog on my website up from that yesterday. And actually what you see is there's some amazing examples of social prescribing money being used to provide health and wellbeing coaches to work in schools, particularly around self-harm and mental health. As these kids try and get to work and try to get to school and to educate themselves in the pandemic, they are incredibly stressed. We absolutely have to support these kids and young people. And that means we need to get some mental health provision of some sort in some way into school environments. And the additional roles funding at the moment is the first port of call for that. When we look at people struggling with life, when we look at people who turn up regularly at GP practices, those are those people who are up the right-hand side of this column here. On the whole, people say it's around social isolation. It's around mental health. What we found actually when we looked at people who are turning up frequently, and this is an example from one GP practice, they don't have loads of comorbidities, they don't have loads of mental health problems. We asked the GPs what it was that it was about, and what they said was, it's actually the majority of these people are struggling with life primarily because they're poor. No amount of 10-minute GP appointment is going to help with that. These are folks who just can't cope. So we have to reach into our communities to help these folks because we can't do it. The NHS cannot do it. Social care probably has a better chance. But actually, we aren't looking for a solution to this. We just keep offering appointments. Those people keep turning up. We have to radically change the way we look after these people. And the first thing is we have to know who they are. What data work are you doing into primary care? This isn't a primary care problem. This is the NHS's problem. How does the NHS understand who's turning up in general practice and how does it best support them? So if we look at poverty, which is probably one of the major issues of people struggling with life, we see that we've got a real problem here. Austerity has been followed by a failure of health to improve and widening health inequalities. Those things are probably linked. And if you look at this graph from the Marmot Review, you see that the most deprived areas have had the biggest hit in terms of local authority spending to support them. And that's a really, really significant issue for them. So the next thing, if we look at people with Black and ethnic minorities, actually we've really got to think about these social norms because COVID's demonstrated that the radical racial inequalities in this country, which are starkly different from many other countries, has become a virus multiplier. And these are even more entrenched potentially as we come out of the pandemic. Now, the NHS's solution to that has not, I don't think, been to properly listen to those folks. They've started to call people sort of risky. So people who are isolated have a higher risk factor, people who've BME a higher risk factor, people in poverty a higher risk factor. I think we have to properly understand these folk, but also what is it that we've been providing or not providing for those folk. And actually, it's not like they haven't been saying, we just haven't been listening. Now, if general practice is rammed with people whose primary problem is poverty, why are we asking for more clinical staff, more pharmacists, more social prescribers? Why isn't the NHS saying to government, actually, the NHS has this much time that is being dedicated to sticking plaster solutions for poverty? And it's a really expensive way of doing it. So I think there is a moment where we have to properly understand these issues, not just risk categorize people, but deeply understand what are the generators, what are the causalities for these folks either not accessing services at all, or when they are accessing them for the wrong things. The NHS cannot help people who are struggling with their housing. It's not the right use of NHS's money. Very interested to know that an ICS has been really trying to work on childhood poverty with local government, because they recognise their spend is spent inappropriately, and they're trying to redirect that and collaborate with local government, which is absolutely fantastic. So we have to understand that. The next thing, systems ownership. So I love this quote from Tim Riley. I think it's fabulous, because what Tim's saying here is that we have to work together on a more collaborative and less transactional world. We need both a patient and a population perspective. And that's the role of commissioning, to step into that space. And I think potentially to step into that space we've just been talking about earlier on, because this is an example of a lady, 2 years of a 2.5-year record that shows her touch points to the NHS. Some of you might have seen this on other blogs. This is shocking. And this does not include GP appointments. This is local authority, hospital, community services, and mental health services. And what we found is that in this situation, that all you're doing is persistently passing the buck, and it just ramps up. Nobody is really meeting that person's need. We have to understand these people properly. If we don't understand them, we can't do anything about, we can't really support them. So we have to get under it. We need the data about these folk. We need deep dives on people who are turning up frequently. We need to understand where they're turning up frequently and why. And we have to see whether there is anything the health system can do about this. At the moment, they're still just rattling around. Why aren't we doing something about it? When you look at acuity in high-performing health systems, they work out what acuity should be dealt with in general practice, what acuity should be dealt with in networks, collaborative networks between health and social care, what acuity should be dealt with at the level of a PCN and an ICS. You need to do that on acuity, on complexity. What are those systems there for? They're not there to performance manage the NHS. They're there to meet different needs, and you need to differentiate those. The next thing is about professionalism. Actually, if professionals really got to grips with the difference between specialism and generalism, it would help. We have far too many specialists and nowhere near enough generalists in our system. And actually, you need both, and we have to value both. We need data to support decisions. Professionals need to belong to teams. We have to organise service to people and communities and put where it's needed. And we need regulation, and only as a safety net. And if we're going to collaborate with people and communities, then what the NHS says is, it says, well, social care, connective, improving internet, supporting volunteers, remote triage. But actually, when I look at what works in shared decision making with people, it's about open access to intelligence. It's about decisions, not consultations. It's collaboration. It's independence, not dependence. We have to move towards that. And so let's build out of this new power share that we have with citizens. Let's move on to collaborating with communities, being a community leader and asking for help. Step out of the way, open up the space, and enable communities to step in. There's a really good example of this happening in Torbay, where they helped people make connection, where they stepped out of the way and supported the community to make friends. And as we know, the more social context, social connections people have, the less likely they are to use the NHS. This is a very significant impact for them in Torbay. Do read the report. And so proactive leaders, what you need to do is focus your effort on sustaining the team, professional relationships, a learning culture that's emerged, provide the data to enable professional decisions, meet needs rather than demand, go work out and differentiate your population, not on illness categories, but on need, not on strokes or heart failures, or don't call people by their diagnosis. Try and understand what sort of lives are people living and how do we help make lives worthwhile, and secure a new collaboration with systems and patients, making the most of what we've achieved so far. Thanks for listening. I hope that was helpful.